Good morning, everyone, and welcome to our International Colorectal Web Meeting. I would like to welcome pediatric surgeons from Chile, Nigeria, Pakistan, Sri Lanka, Tunisia, Algeria, Turkey, Dominican Republic, Russia, Colombia, Mexico, Cameroon, Argentina, Saudi Arabia, Ecuador, and United States. If I miss your country, please type at the chat and we are going to acknowledge at the end. So the first case, I'll be presenting it. I thought it was interesting for the discussion and also because we always get this question. So I thought it would be good to present our rationale. This was a newborn male patient with anorectal malformation. He had family history of Townes-Brocks syndrome with mother and sister with the syndrome and with anorectal malformation. He also had the syndrome. The syndrome's features include anorectal malformation, dysplastic ears, and thumb malformation. Other signs and symptoms that may be present: kidney abnormalities, mild to profound hearing loss, eye abnormalities, heart defects, foot abnormalities, and genital malformations. And it's because of a mutation in the SALL1 gene. So this is the abdominal X-ray 24 hours after birth. And when we are looking at the first X-ray or the babygram, we want to see that the NG tube goes all the way, so the patient doesn't have esophageal atresia. We want to look at the vertebra, make sure there is no vertebral abnormality. We want to rule out duodenal atresia with a sign of the double bubble. And then we want to look at a very important portion, the sacrum, in patients with anorectal malformation. So here we are seeing a good sacrum, and we see the dilated rectum all the way down in the pelvis. So this is the lateral view, and again, we can confirm that this patient has a good sacrum. And if we look carefully, we're gonna see that there are bubbles of air all the way to the perineum. So without examining this patient, we should suspect we're dealing with a rectoperineal fistula. So here is a little bit later, and you can see that the gas decreased, meaning that somehow he's passing gas. The bowel is still distended, but somehow he's passing gas. So without examining the patient, we should suspect this is a case of rectoperineal fistula. And here you can see also the gas all the way down here. And this narrowing that we see right at the bottom is the effect of the muscle compressing the rectum. So this was the anatomy when he was born. And here you can see the tiny opening that it's the rectoperineal fistula. Here you can see the thumb abnormality. He has what appears to be two thumbs. Normal kidneys, normal right kidney, normal left kidney. And now we are ready to operate on the patient. So the patient is prone, face down, and it's hard to see, but there is a tiny opening. And in this case, we only had to mobilize the posterior wall because the perineal fistula is a spectrum. So in this case, it was within the center of the sphincter, a little in the anterior side. So just by opening and mobilizing the posterior wall, we were able to place the anus in the center of the sphincter. And that's the end of the operation. So 2 weeks after surgery, parents were taught the protocol of anal dilations. They were doing it correctly, and the patient was stooling daily, until 2 months after surgery, when the entire family had a viral respiratory infection, and then the patient stopped stooling. He presented to the hospital with this abdominal X-ray, And what you can see here, it's a marked distended colon. And here's the lateral view. There was concern for pneumatosis also, but you can see that it's a very distended colon, sigmoid. So with this image, what would be your next step? Digital examination to rule out anal stenosis, contrast enema, rectal irrigation, observation, or more than one answer. Everybody can vote. And we'll see the results. So we have a divided audience with the majority saying rectal irrigation, but some of them saying more than one answer. I think more than one answer is good, but the first thing you as the surgeon has the obligation to rule out is a stricture. Even though you thought the family, you know they are doing, you have to check yourself. Does this patient has a stricture? Because if the patient has a stricture, it would explain the entire picture. So I think the first is to rule out anal stenosis. So I personally did, and there was absolutely no anal stenosis. I could pass even my big finger without any trouble. But surprisingly, there was also no stool in the rectum. So the patient was also not constipated, but had this abnormal amount of air in the colon. So at this moment, I said, I don't know what's happening. Maybe it's just a consequence of the viral infection. Let's do rectal irrigation to decompress him and then follow up in 2 weeks. So we saw him 2 weeks. The parents were doing rectal irrigation. Baby was eating. But looking at the growth curve, the baby was not gaining weight. He was always small for age since birth. And he was not stooling in between rectal irrigation. So at that time, we decided, let's get a contrast enema just to be sure. So we got the contrast enema, and these were the initial images. So you can look here, it's a non-distended rectum, and suddenly we see that there is a more distended piece of bowel that as they progress the contrast, it seems to persist that this area is more distended than this one. So with this clinical picture, we thought with a syndromic patient, no anal stenosis, presented with an episode that seemed like enterocolitis, with the contrast enema, I felt in this case for the first time that I had to biopsy to rule out Hirschsprung. It's important to remember that it's extremely rare, the association of anorectal malformation and Hirschsprung disease, but in this case, I felt it was important to rule it out. So we did the biopsy about 3 centimeters from the anal verge from the mucocutaneous junction, remembering that patients with anorectal malformation don't have an anal canal. So I did as high as I could, as safe as I could, and the biopsy came back normal. Normal ganglion cells and no hypertrophic nerves. So what would you have done if this biopsy came back negative for ganglion cells? Proceed with the pull-through for Hirschsprung, repeat a full thickness biopsy at the peritoneal reflection from the abdomen, open a colostomy, or I don't know. Everybody can vote. And let's see the answers. Very good. The majority said repeat a full thickness biopsy at the peritoneal reflection. And that's the main reason why I'm presenting this case. If you suspect Hirschsprung, first of all, very unlikely that it's going to be Hirschsprung. Most patients with anorectal malformation have severe constipation. It's not Hirschsprung. But in this case that I suspected, even if the initial biopsy came up saying that it was Hirschsprung, I still have to doubt myself. So I told the family, I'm doing the biopsy today. If it comes normal, end of the case, he doesn't have Hirschsprung, good. If it comes abnormal, I am still not sure. I'm gonna do a higher biopsy because we have too much to lose if we proceed with a Hirschsprung pull-through and then we end up finding out that we just biopsy the abnormal area in patients with anorectal malformation. So you really have to doubt and be 100% sure about the diagnosis before offering a pull-through. And the points of discussion, again, always doubt and double check of this rare association, because if you have a patient with anorectal malformation, in this case, normal sacrum, good malformation that had a good operation that will have bowel control, if on top of that, I do an operation for Hirschsprung and I remove the distal portion, this patient will now be fecally incontinent for life. Therefore, I can only proceed with a pull-through if I have zero doubts that this patient indeed has Hirschsprung disease. So in this case, it was not Hirschsprung disease. Good news, the patient is now on laxatives and is stooling without problems. What happened? I suspect it was a reaction from the viral infection. Don't have full explanation, but it's definitely not Hirschsprung. You want to comment?
What happened to the biopsy?
The biopsy was normal. No Hirschsprung.
Okay. So this presentation, I think, is very important because we have seen many patients in which the surgeons suspected that the patient had Hirschsprung in addition to anorectal malformation, went ahead with the pull-through, and patients end up being totally incontinent. Of course, there is an association between Hirschsprung and anorectal malformation, but we believe that is much less frequently than what people believe. And we pediatric surgeons all over the world are trained to suspect Hirschsprung disease in every patient with constipation. But Hirschsprung is something much more than constipation, as you know. They is a patient with enterocolitis. They are very sick. It's very different from just plain constipation. So our experience is that Hirschsprung in anorectal malformation, I think I remember that we had like
cases. Four cases.
We had 4 cases of demonstrated Hirschsprung, but we are talking about a series of about 4,000 cases. So it's extremely unusual from our point of view. On the other hand, we have seen many patients that came to us in which the surgeons are suspecting Hirschsprung and the patient never had Hirschsprung.
So I see in the chat many people asking to share a screen. Is everybody seeing the screen? Because I hope they are, because I just did the entire presentation. So if somebody can just, yes, okay, people are seeing the screen, wonderful. So this is a publication that we did showing that we only had 4 cases. The 4 cases, they all were syndromic patients. And I think this is an important portions to emphasize. And that's one of the reasons why I was more suspicious in this case that I presented. So now it's my pleasure to invite our next presenter, Dr. Diego Martinez from Mexico. Please welcome.
Thank you, Dr. Bishop. I will share my screen now, so I hope everybody can see the screen. Perfect. So hi, everyone. First, I want to thank Dr. Peña and Dr. Bishop for the opportunity to be here today. We will present a case of a 8-year-old male who came to our institution by his own, of course, with his parents. His medical history at birth was normal, and we say normal because we will see what happened next. So he has been constipated since childhood, and a late diagnosis of an anorectal malformation with perineal fistula was made at 4 years old, and he had a colostomy opening. What we know is that he has been urinating through the anus. Urology at other institutions made the diagnosis of urethral stenosis with a rectourethral fistula. A cystoscopy was opened and he started on urethral dilations with no success. So we first met him in February 2022 in the urology outpatient clinic. Once again, he came in on his own looking for a second opinion. He had a cystostomy, a colostomy, and urethral stenosis. Urology ordered a cystogram, as you can see in the image, where only 30 milliliters of contrast were injected. Unfortunately, the patient was really uncooperative, and they cannot see the fistula, neither the urethra. We first met him at the Colorectal Center in March 2022. We also did a distal colostogram and a cystogram at the same time. We can see maybe here a fistula. We were not really sure. The patient was also really uncooperative. So we met with urology, present this case, and decide to perform an exam under anesthesia, a cystoscopy, and new colostogram in the OR if needed. So on the exam, we found an anorectal malformation with rectoperineal fistula. The cystoscopy was done and there was no proximal urethra. And what we found is a rectourethral, more specific, a bladder neck fistula. And as you can see in the image, the cystoscope go into the cystostomy and exit in the rectoperineal fistula. So this is our diagram. We have the urethral stenosis, only the most distal part was open. And then the stenotic part was about 6 to 7 centimeters. So we have to go into the cystostomy. This is the bladder. This is the bladder neck fistula. This is the rectum. And it was, the length of the fistula was 1 centimeter. It was located 1 centimeter above the edge of the skin. So it's a rectourethral fistula. So our diagnosis was an anorectal malformation with rectoperineal fistula, rectourethral fistula, and distal urethral stenosis with a hypertrophic pubic bone. So with urology, we're planning a PSARP and anterior urethral mobilization. So in the first image, we can see the fistula located anterior to the center of the sphincter. And in fact, just by pulling out the skin, you can see the fistula and the rectum. We started with a posterior sagittal incision. The entire sphincter mechanism was divided until we were able to identify the white fascia that covers the posterior rectal wall, continue the dissection on both lateral sides and down to the skin. And once again, we have a better view of the fistula and the rectum. We place multiple silk stitches first in the posterior edge of the rectum in order to apply traction and place a Foley catheter in the rectourethral fistula. At this point, we place multiple silk stitches in a circumferential manner in the edges of the rectum, and the next step was the mobilization of the rectum and dissection of the anterior rectal wall closer to the rectum and away from the urethra. Once the rectum has been completely separated from the urethra and mobilized, we use the rectourethral fistula as a near urethra and place it in the anterior perineum. We repair the perineal body and place the rectum in the limits of the sphincter in the usual manner and finishing with the anaplasty. Patient was discharged at day 5. We saw him in the colorectal clinic 2 weeks postoperative and started dilations with Hagar 15, and we're planning to perform a distal colostogram in October. Meanwhile, urology saw him in the outpatient clinic and removed the Foley catheter 1 month after the surgery. The patient is urinating on his own through the neourethra, and they are planning to do a urethroplasty with mucosal graft. We want to thank our urology department because we think it's really important to be working together in order to achieve better results. Thank you.
Thank you very much, Dr. Martinez, for this beautiful case. We call this the absent penis spectrum. So there are patients that are born without the penis They have the bladder, the urethra is posteriorly deviated and it opens in the anterior rectal wall. This can happen with a normal anus. This can happen, like in your case, with a perineal fistula. This can happen also when the patient has a penis and has a stenotic urethra and a good urethra deviated to the back. So congratulations on your case. The key is to separate the rectum from the urinary tract, and just like you did, mobilize this urethra forward. And then the hard portion is for the urologist to reconstruct this urethra, which is not an easy task. It's almost as if the patient has a hypospadia in the perineum. The beauty of it's because the bladder neck usually is intact, so the patient has urinary control. But the urological reconstruction of the urethra is not so easy, but hopefully this patient will have a good outcome. And since the patient had a perineal fistula, has normal sacrum, the patient should also have bowel control. I had an adult patient that had the full spectrum. Well, he is now an adult patient. He was a child when I met. But unfortunately, the surgeon did not recognize the anatomy and treated as a rectourethral fistula and just ligated and destroyed that good urethra, which was a mistake. So that patient ended up with a Mitrofanov because all the urethra was completely destroyed. So congratulations on your case. Do you want to comment?
See, this kind of case emphasizes the importance of having a good index of suspicion. You can only have a good index of suspicion when you read a lot or when you have personal experience. For that, you need many cases because this is an unusual malformation. And so that emphasize the importance of having more and more colorectal centers where all these cases concentrate and the surgeons have enough experience to recognize this. So as Dr. Bishop said, the next steps for the urologist is challenging because it's not easy to reconstruct that urethra. It takes several operations. We have cases like that. Congratulations, Diego, congratulations, Emilio.
Yeah.
Any questions from the audience? I don't see any questions. Somebody said, great job. Perfect. You can stop sharing your screen and then I'm gonna present. We always think that we don't discuss bowel management enough. So I thought about presenting a few bowel management cases today. We feel as surgeons, we all love to operate, but if we just operate and we leave the patients untreated, our benefit is very small. So bowel management is really what comes together with a good operation. So patients should never be abandoned. So this is an 18 years old male patient. I think most of you know that our team, the colorectal team, is present in the Spina Bifida clinic. So we met him at the Spina Bifida clinic. He's a wheelchair user, currently not doing bowel management. And at 18 years of age, he was still stooling in diapers. This is a highly functional man. He works every day. And when approached about bowel management, he was thrilled and very enthusiastic. Question for you, what is the best predictor for bowel control in patients with spina bifida? The level of the lesion, the urinary control, the frequency of bowel movements, or I don't know. Everybody can vote. And very good, not very good. The best predictor is actually having urinary control. So if I'm meeting a patient that is 18 years old and I want to know what his potential for bowel control, I should just ask if he has urinary control. That's the best predictor. We just had a publication actually from the institution, what's the name of the hospital? I forgot, that Emilio works.
Hospital Infantil de México.
Hospital Infantil de México. Forgive me, Emilio and Diego. So we had Dr. Alfredo Dominguez with us, and he studied all of our patients with spina bifida. And that was one of the conclusions of the study, that the best predictor for bowel control in patients with spina bifida is urinary control. So we always start bowel management with a contrast enema. Why? Because that gives us an idea of the anatomy, gives us an idea of how this colon functions, and it allows us to correctly evaluate the abdominal X-ray on the following days. For an unknown reasons, patients with spina bifida, they have a non-dilated colon, but behaves as a very slow motility colon. So that's what we are seeing here. It's a non-dilated redundant colon. We don't know why it does not get dilated, but it functions as a very slow motility colon. So our patients, they do the contrast enema on a Thursday, and then on a Friday, we start bowel management and they come for consultation. So this man came for consultation, and the next day abdominal X-ray film, we can see that we still have contrast material, just confirming that we are dealing with a slow motility colon. So we taught them how to do the enema, and the first recipe that we decided for him was 500 ml of normal saline and 40 ml of glycerin. Here in Colorado, we always start bowel management on Friday. Patients will do enemas during the weekend and on Monday, and they will come for an X-ray, and they will tell us the report. We want to know how was the enema. If after the enema they had a response within the 1 hour, we want the entire process of enema, infusion, retention of the enema, and then evacuation to be 1 hour. And then they will come on Monday with reports. We want to know if they passed stool, if they had accidents. We call accidents when they pass stool in the underwear after the enema. How many hours after the enema? What was the amount that he passed? So this is the abdominal X-ray on Monday. And because I have a contrast enema, I know that his colon is in the right anatomy. So the rectum is clean. The descending colon is clean. That's what we want after an enema. And we see a little bit of stool in the ascending colon, which is not a problem because it usually takes 24 hours for this stool to reach the rectum again. And the patient was extremely happy because for the first time in his life, he was completely clean in the underwear. So this was the first abdominal X-ray. On the next day, we can see persistence. The X-ray continues to be clean. The patient was still clean. And final X-ray, patient is still clean. Again, just a little bit of stool in the ascending colon, which is not a problem. So this is a patient that was 18 years old when we met. Hopefully, because now we meet patients as soon as they come to the clinic. This is a scenario that we will no longer see. We want to catch those patients early in life and start bowel management at an appropriate age. Any questions about this case before I move to the next scenario? Any questions?
To comment.
Yeah.
I understand that we all pediatric surgeons like to operate. So by definition, pediatric surgeons and surgeons in general don't like the idea of performing medical treatment. And bowel management is basically about medical management. So most surgeons try to stay away from that. In theory, the surgeon should operate and the bowel management should be done by gastroenterologists and pediatricians. but the real life is not like that. The fact is that bowel management was born by surgeons and is performed by surgeons. And are surgeons the ones who have the experience with bowel management. And we cannot refuse, we cannot leave these patients abandoned. Also, we are responsible for the results of our operations and the follow-up of our patients. So, and also an advice for pediatric surgeons all over the world, you want to get patients, pediatricians referring patients to you with anorectal malformations. One way to do it is doing bowel management, because everybody will know about you and they will be sending you patients. So in addition, the bowel management will bring you many patients because the communication from parent to parents. And finally, the spina bifida patients are, in some hospitals, there are clinics dedicated to spina bifida patients. Not all children's hospitals have that. In Denver, Colorado, there's a big clinic for spina bifida. And the enormous majority of spina bifida clinics don't have a surgeon, a colorectal surgeon advising how to manage the patients. So the experience in this hospital with Dr. Bishop is that for the first time, they offer their services to the patients of spina bifida, and they benefit many patients that they were managing the spina bifida clinic, but they were dirty in the underwear. So I suggest the colorectal surgeons or all the pediatric surgeons that are listening to this, approach the clinics with the spina bifida, and you will be able to benefit many patients simply by applying the principles of bowel management.
So now I'm going to present another case, another scenario also for bowel management. This is a 5-year-old male patient born and operated due to a recto-urethral prostatic fistula. So my question for you is, what is the prognosis for bowel control for patients with recto-urethral prostatic fistula?
Good operation.
With a good operation. Everybody can vote. Sorry, I closed the poll and I don't see it. Do you see it, Ray? Perfect. Here's the answer. So we have a very mixed audience, very optimistic audience. So the reality is rectoprostatic fistula, the prognosis for bowel control is not that good. It's 65%. So it's not that good. This is a patient that was operated on by me. So he has been managing his constipation up to now. And now 5 years old is the cutoff for bowel control in the United States, because it's when kids go to kindergarten and they have to be perfectly clean in the underwear. He was doing well at home, but the bowel management was not perfect. So because he had a rectoprostatic fistula, 65% chance of bowel control, I told the mom we have to start him on enemas. We want him at school perfectly clean. So again, we do a contrast enema so we can see the anatomy of the colon. We know where to look in the abdominal X-ray, and we can see his colon looks more towards one side, almost as if he is a non-rotated patient. So he came to clinic. He had his contrast enema a few days before. It was not the day before. And we can see that he has moderate amount of stool in the rectum and in the colon. So we started him on 300 mL of normal saline and 25 mL of glycerin. So again, this is on a Friday. They're going to do the enema Saturday, Sunday, and Monday. And Monday, they do the enema, they evacuate, they come for an X-ray. We want to make sure that after they are done with the enema, the rectum and the left colon is completely clean. And we want to know the report of what happened. So not all patients, we get it right the first time. This was a patient, he was in a good regimen before, so it's easier when the patient have been well managed. So he was clean since day one with 300 mL of normal saline and 25 mL of glycerin. Just remember that when you're looking at the X-ray, you want to make sure that the rectum and the left colon is clean. This is just to show 2 abdominal radiographs that he was clean. Patient was able to go to kindergarten now 100% clean in normal underwear. For this type of patients that have borderline bowel control, our recommendation is send them to school on enemas for a year, and then during the summer break, that in the United States, it's usually 2 or 3 months, we can try laxatives again when the child is more mature to see if they can stop enemas. And we're gonna try a few years. They already have a regimen that works. They have a routine that keep them clean, but we can always try and see if they can achieve voluntary bowel movements and stop using enemas. Let's suppose they do 1 year, not perfect, go back to an enema. Do another year, still not perfect. Then at some point, the family will realize that the patient cannot be 100% clean on laxatives. That's when we will think about a way to give independence to this patient. That's when we would propose the Malone procedure if we feel that enemas are the treatment for life in this patient. Any questions about this case? I don't see any questions, comments. So now we're gonna move to another scenario. This is a 20 years old female patient that was born and operated due to a rectal perineal fistula. This was not a patient of ours. She has suffered from fecal incontinence all her life. She was taking Miralax daily. Now, the question for you is, what is the prognosis for bowel control in a patient with a rectal perineal fistula, normal sacrum, and good surgical repair? Everybody can vote, and let's see the answer. 100% correct. So this is a 20 years old that has suffered unnecessarily all her life because she was not properly followed and her constipation was not properly treated. So here you can see she has a normal sacrum. That's her abdominal X-ray. That's her contrast enema, showing a dilated rectal sigmoid, not too bad, but dilated. And then she came for the first consultation on a Friday. Our patients always have to watch a lecture about what the bowel management week entails. So they learn about the possibility of enemas and laxatives. She's at 20 years old. She was terrified about enemas. She was, please tell me that I won't need enemas. And I told her that I thought her chances of needing laxatives only were very high and that I would try to avoid enemas on her. Unfortunately, she came to us with a stool ball. So in the ideal world, I would have liked this patient to receive enemas just to disinfect her and then start her on a laxative regimen. She was so terrified that I decided to try a glycerin suppository and start her on 4 squares of X-Lax to see if we could avoid enemas for her. So the next day, on Monday, she comes and you can see it has less constipation compared to the day before, but we still have significant amount of stool in the rectum. So on that day, I was able to convince her to do an adult fleet and increase to 5 squares of X-Lax. Those are senna-based laxatives. They are stimulant laxatives. They are the ones that work best in patients with anorectal malformation and idiopathic constipation. So each square in the United States has 15 milligrams of senna. So the next day and the following week, she was successful and clean with 6 squares of X-lax. She was having 2 voluntary bowel movements daily, and she could not believe what a change in her life she had on that 1 week. So the reason why I selected those 3 cases is just to give you an idea of how much we have to do for bowel management. So in these 3 cases, 2 of them were adults that suffered their entire life because they were not offered bowel management. The third patient is a patient that has been in the right path, so he will be treated correctly since the beginning. So I think the responsibility is on us, surgeons that operate on patients with anorectal malformation and Hirschsprung and see patients with constipation to not abandon those patients. Those are patients for life. They need to be followed, and they all need some sort of bowel management. So it's very important to follow them and to put them in the right path so they can be clean in the underwear. Any comments?
Yes. Well, when the lesson from this case is that a patient that was born with a perineal fistula that comes to you after several years complaining of fecal incontinence, either was born with a bad sacrum or had a bad operation or suffers from pseudo-incontinence. Pseudo-incontinence, we call it, when actually what those patients have is severe constipation and soiling constantly, like many children that you see without anorectal malformations who soil the underwear because they are severely constipated and chronically impacted. So remember, either had a bad operation or had a poor sacrum or actually suffer from pseudo-incontinence. So, and we call it pseudo-incontinence because those patients improve with the with the use of laxatives, like patients with no anorectal malformations.
So there is a very good question from Dr. Tayaba. How do you calculate the volume of the enema based on the age and weight? So there is no calculation. What we do is we look at the contrast enema. Because we have done bowel management for so many years, it's easy for me to determine which one I'm gonna start. So if you're just starting bowel management, my recommendation would be to ask your radiologist to measure the volume that he or she needed to fill the entire colon. You can use way less than that. 1/4 of that volume will probably be enough. So if the radiologist used 1,000 to fill the colon, you can start with 250. That is just an estimation. The reality is, if you ask me the most popular enemas, I always say, if you're going to start bowel management, start with those recipes. The most important message is to follow the X-ray and adjust on the next days. The enema that you start is not the most important one. But if you need a recipe, I would say the most common ones are 300 mL of saline and 15 of glycerin, 400 mL of saline and 20 of glycerin. If it's a big patient, 500 mL of saline and 40 mL of glycerin. If you start with one of those, then you're going to see the report of the patient and the X-ray. If the X-ray shows stool and the patient had accidents, you have to increase the glycerin, sometimes also increase the volume. Then you're going to see the X-ray next day. And that's how you will learn to do bowel management. It's trial and error. And you have to compare one X-ray with the other. The most important thing, you want the rectum and the left colon completely clean immediately after the enema. That's going to guide you what you have to do next. What laxative do you use? We use Senna. We use a stimulant laxative. In the United States, the brand is called X-Lax, but it's a Senna-based laxative. Same thing. We go way beyond the recommended dose. So based on how, I didn't show any case of idiopathic constipation. I showed one case of constipation with anorectal malformation. She was 20 years old and she ended up being with 60 milligrams of senna. So the dose is between 15 and 100 milligrams of senna. So that's our range. And you can increase or decrease. Most patients with anorectal malformation, because we need the right consistency of the stool, if the stool is too liquid, but the x-ray is not clean, we cannot decrease the laxative. We just add fiber to bulk the stool. So we like Benefiber. It's a fiber that just bulk the stool. When do you indicate rectal biopsy for idiopathic constipation? That's a very good question. Extremely unusual for us to need a biopsy. If you think about the contrast enema, the difference between a Hirschsprung patient that you're going to see a non-dilated portion and then a dilated portion, from an idiopathic constipation that you see the dilation all the way to the end. We rarely do biopsy in patients that just present with idiopathic constipation. Hirschsprung is more than constipation. Hirschsprung is the patient that doesn't grow, the patient that has history of enterocolitis. Hirschsprung patients don't soil. So there are many things that can differentiate one from the other. I think I answered all the questions. Any other comments?
No.
Well, I think we finished our meeting today earlier. If there is any topic, we don't have senna. What is the next option? So it depends on your country. I would say the best option are stimulants, laxatives. Bisacodyl is another one that works, but it's just, you would have to see from your country which stimulant laxatives you have. So our next meeting is scheduled for September 21st. If you have a specific topic that you would like to see, please let me or Ray know. And if you would like to present a case, please send your PowerPoint. All cases are good. We all like to learn from each other. Simple cases, difficult cases, exceptional cases. We learn from all of them. So thank you very much for joining us. And again, today we had pediatric surgeons from Chile, Nigeria, Pakistan, Sri Lanka, Tunisia, Algeria, Turkey, Dominican Republic, Russia, Colombia, Mexico, Cameroon, Argentina, Saudi Arabia, Ecuador, Philippines, Ghana, Spain, Brazil, Indonesia, Uganda, Ethiopia, and United States. So thank you very much, and we hope to see you next month. Bye-bye. Oh,
Quiero ver una radiografía.
thank you.